Good afternoon, everyone. My name is Marcia. I am a member of the Jamaica Diaspora Task Force, Health Task Force. I work with the public health surveillance sections and the infectious diseases sections. I was invited here by Drs. Gordon, Frey, and my team at the Health Task Force, along with all of the Jamaica Diaspora group, to give a talk on COVID, understanding COVID-19. This is an overview of the pandemic as it stands now. It's a review. So it is a review because at this point in the pandemic, public health practitioners as well as others are aware of the broad outline of this pandemic. We know that it is serious. We know that it is deadly, and we know that it is all encompassing. However, it is important that as practitioners, we refresh our information, we refresh our facts, we realign ourselves with new information or information that we know, and we try to get new information out to the public and to ourselves. So this is the purpose of this review of the pandemic. All right, I'm going to begin by giving a bit of some background information that may include or will include some basic definitions that we are mostly familiar with, COVID and SARS coronavirus, the causative agent. I will discuss key dates in the pandemic. I will give an epidemiological overview of the pandemic as it stands right now. I'll spend the bulk of the time discussing transmission. So how is coronavirus transmitted from an infected person to a non-infected person? What are the major routes of transmission? I will then go on to discuss COVID-19 disease. I will present some information on the pandemic as it exists now. And I will end with a discussion of the next phase of the pandemic, or what we believe, what scientists believe to be the next phase of the pandemic. This is a definition that most of us as public health practitioners are familiar with. COVID-19 is simply coronavirus infectious disease 2019. SARS-CoV-2 is severe acute respiratory syndrome coronavirus 2. We as public health practitioners and many people in the public are familiar with these definitions, but it's incumbent upon us as practitioners to not use these terms interchangeably. Myself, I am guilty of doing that at times. I find myself saying the person has the corona, or the person has COVID disease, or the person caught COVID, or the person caught corona. They are not interchangeable. We do use them in that way, but it is incumbent upon us that we try to maintain some correctness in the definition. I have heard people in the public say to me, but if I have COVID, can I get SARS, or vice versa? They are not aware that these are not two separate diseases, but that one is the causative agent, that is coronavirus or SARS is a causative agent, and COVID is the disease that may result from an infection with SARS-CoV-2 called corona. So it is important that we keep these terms clear and we do not use them interchangeably, as much as we're sometimes, for brevity or just familiarity, want to do so. Here I present an overview, or just an overview of the variant particle. All of us are familiar with this picture. We know what it is. It is the coronavirus. It's called corona because of that crown of thorn appearance of the virus. SARS-CoV-2 is a single-stranded RNA virus. It is composed mostly of proteins. So there are more proteins, but the main proteins are an envelope protein designated E, There is a membrane protein designated M, and there is a spike protein that is designated S. We are familiar with the spike protein. It is a part that sticks out, that red bit that I highlighted here in yellow. The spike proteins are absolutely critical for entry into the host cell. So this is the part of the variant particle of the coronavirus that attaches to the receptor cells on the host cell. So for every cell, we have receptors for various things. The red bit here, the spike protein, attaches to all receptors, and then from there can inject its genetic material. In this case, it's an RNA, so it injects the RNA into our cell nucleus, replicates, and then is passed on in that manner. The spike protein here in yellow is also the key target for antiviral and for vaccine action. Unfortunately, the spike protein is the part of, or one of the parts, the most important part of this variant particle that gives it its high mutability. So it's the possibility of it mutating to other forms, some forms that may be more virulent than the others. We realize that Delta was possibly a more virulent strain than the wild type or the alpha type coronavirus. Omicron is apparently less virulent, but more transmissible. But this red bit here, the spike protein, is largely responsible for that mutability. Okay, I'm going to discuss now some key dates in the pandemic, in the evolution up to the pandemic. In December of 2019, so the very end of the year, the World Health Organization, WHO, receives media statements submitted by the Wuhan Health Commission about cases of viral pneumonia in Wuhan, China. Now, before that, as early as October, we believe, there were reports by the health authorities in Wuhan, scientists and physicians, to the commission about viral pneumonia cases in the area. However, it was not until December 31st that we had an official word from Wuhan to the World Health Organization about these cases of viral pneumonia. Very soon thereafter, on the 2nd of January, 2020, WHO informs Global Outbreak and Response Network partners about clusters of cases in Wuhan. Now, GORN, the Global Outbreak and Response Network, is a consortium of about 250 partners and technical teams that are responsible. They're charged with responding to public health events, so acute public health event, for example, this pandemic or other epidemics or emerging diseases. They exist in numerous countries across the world, but they work under the umbrella of WHO. Their main office is in Geneva, the headquarters of the World Health Organization. They are strong partners for WHO, and they assist countries with the systems that they need to battle and to counteract, to mitigate, to contain various emerging diseases. With the work of WHO, on the 5th of January, with the work of GORN, WHO issues its first outbreak report to the world. On the 9th of January, 2020, WHO reports that Chinese authorities have determined that the outbreak was caused by a novel coronavirus. On the 11th of January, WHO receives the genetic sequence of the novel coronavirus. This, for vaccinologists, people who deal with and study vaccines and develop vaccines, and for virologists, they're strong partners in this effort. This is the seminal date. This is the date that they understand what the positive agent is, what the microbe is. It's a coronavirus. They get the sequence of this virus. At this point, vaccinologists, along with their partners, virologists, epidemiologists, immunologists, and others, can start to develop medication or develop a way of managing the disease or the causative agent and effects of the disease. So they start on vaccine development. On the 21st of January 2020, WHO reports clear evidence, very clear evidence of human-to-human transmission of the coronavirus. This is another very, very seminal date in the evolution up to this pandemic, because without this designation of human-to-human transmission, we would not get to the point of declaring a pandemic. Obviously, at this point, WHO had reports from different parts of the world, different WHO regions, about human-to-human transmission of this causative agent, the coronavirus. On the 11th of February, 2020, the novel coronavirus is renamed SARS. So before there was already a coronavirus called SARS from 2003. This one is renamed SARS, SARS-CoV-2, and the resulting disease is renamed COVID-19. This is done following best practices to avoid inaccuracy and stigma. In 2015, the World Health Organization put out a document outlining a new naming convention. This was done to avoid the use of place names. For example, Ebola is a river in the Congo region. Crimean Congo hemorrhagic fever from Crimea area and from Congo. We no longer use these type of names. Creutzfeldt-Jakob disease. We do not use people's names or the scientists' names anymore. We do not use the names of animals. We do not use the name of humans or plants in designating the microbe or the disease. And obviously this is to avoid stigmatizing a place or a person, an animal, or plant. We had started this by calling this the Chinese virus or the Wuhan virus and various iterations thereof, who obviously does not favor this way of naming diseases. And it's good that we do not do that. We do not want stigmatizing events around diseases. We're all aware of how deleterious that can be for people's lives, and also just understanding what the causative agent and what the disease is. On the 7th of March, COVID cases surpassed 100,000 globally. So we had reports of over 100,000 COVID cases globally. March 11th is the seminal day. It is the most important date in this pandemic. This is the date where WHO characterizes COVID a pandemic. It's no longer an epidemic. It's no longer an endemic disease. It is something that has spanned the globe. Now, countries are required to react, to set up the infrastructure that is needed for containment and for mitigation. On the 4th of April, just a little bit less than a month later, WHO reports 1 million confirmed cases of COVID globally. On the 7th of March, there were 100,000. Less than a month later, we confirmed 1 million globally, a huge increase from only less than a month ago, 3 weeks ago. We're moving forward quickly to December 31st, 2020. WHO issues its emergency use validation for the use of COVID-19 vaccines across the world. Obviously, between April 4 and December 31st, there was a lot happening, a lot of different dates, a lot of different things happening, but this is an important one because within a few months, really, half a year of a declaration of a pandemic, we have vaccines ready to be launched. These vaccines had been in development for decades. So the technology behind them, especially the mRNA vaccines, which I will not really touch on here, I'm not a vaccinologist, and you can find more information about vaccinology elsewhere, but those had been in development for very many decades. But with the declaration of a pandemic and the financial resources targeted to that, we had within a very record time the development of a vaccine to counteract coronavirus. All of the activities surrounding the designation of a pandemic and leading up to it happens within these phases. They're not mutually exclusive as they appear here, but they are the important phases that we need to go through before we can declare a pandemic. Obviously, in phases 1 and 3, we have predominantly animal infections, so few human infections. Phase 4 is critical. Here we have reports and evidence of sustained human-to-human transmission. That gives us the information, the facts, and the bases for designating a worldwide pandemic, which is what happens in phases 5 through 6. Within these phases, between phases 4 and phases 5 to 6, obviously there's a lot of back and forth between countries, between the World Health Organization, between their partners, as to the information, the scientific basis for declaring a pandemic. It is a disruptive event. It's financially devastating for some countries. It's financially difficult, as we know, but it is important that we make sure that we designate it correctly. And so what happens between phases 4 and phase 5 and 6 is very important. Ultimately, on the 11th of March, 2020, the World Health Organization declared the world in a pandemic. Later on, we will discuss the post-peak and the post-pandemic phases. All right, next I'm going to switch to an epidemiological overview of the situation as it stands as of this morning when I checked the site. I'm going to concentrate on the Americas, so North America, Latin America area, and then I'll give some information about the Caribbean region and focus on one island. I'll focus on Jamaica for the purpose of this talk. At this point, the last time I checked this morning, we were at 426,551,362 confirmed cases of coronavirus around the globe. Most undoubtedly, this is an underestimate. Deaths, as of this morning, we're at 5.9 million. This too is probably a gross underestimate. In most countries, we do not have the infrastructure, the reporting infrastructure to really accurately define all cases. And obviously many people may have an infection, but they're not ill enough to go to the doctor or to get tested. Many deaths in different countries are not coded COVID if the person had an underlying issue. So we obviously most likely have an underreporting of death. But as of this morning, we're at 426 million plus cases around the globe and 5.9 million deaths around the globe. 10.4 million doses of vaccines have been administered across the globe. We're going to have to do better than that if we want to have 70 to 75% herd immunity by the end of the year. All right, now looking at the Caribbean and Atlantic Ocean islands. The Caribbean here also includes the continental Caribbean. So Suriname, Guyana, and French Guyana also is included in this list. There are 32 countries in this region. Right now, as of this morning, we are at 3.1 million cumulative cases of reported and confirmed coronavirus. And deaths are, as of this morning, 31,500. We have a case fatality rate in the Caribbean and Atlantic Ocean islands of 3.0. Now, case fatality here is the ratio of deaths to the number of cases. So cases being the denominator and deaths being the numerator for this ratio. This is what we call a highly contextual measure. It varies. It varies according to the country. It varies according to the healthcare system. It varies according to the reporting system. And so it is a somewhat rough estimate. Sometimes we call it a crude estimate of how many people are dying given a certain type of illness. At this point in the Caribbean, it's 3% of people dying who become ill with COVID. Focusing on lovely Jamaica, we have cumulative cases as of this afternoon, 127,665 cumulative cases around the island. Deaths as of this afternoon, when I checked, 2,787. We have a slightly lower case fatality rate in Jamaica, so 2.0%, 2%. And we have 1.3 million doses of vaccines that were administered to residents of the island. It is estimated that about 21% of the island has been fully vaccinated. We really need to do better than that if we want Jamaica to be at the forefront of being past this pandemic, being innovative, being pioneers in getting past this pandemic before others do. But at this point, we're at 21%. It's not terrible, but we need to do a lot better. Looking at the parish level, deaths within different parishes. Highest number of deaths occur in Kingston and St. Andrew Parish, so 600 in those two parishes. In St. Catherine, we have 389 deaths. In St. James, we have 252. Now, the highest number of deaths clearly occur in the most urban or most densely populated centers of the islands, Kingston and St. Andrew being the capital part of the country, St. Catherine, which is contiguous with Kingston, St. Andrew, and St. James, which is a big tourist center of the island, has the biggest numbers. Lowest number of deaths occur in Clarendon, in St. Thomas, and in Portland. I imagine that these are more sparsely populated parts of the island. And so we see the lower numbers here. We still have some fairly high numbers in St. Elizabeth, Westmoreland area, and St. Anne Parish as well. All right, next we're going to discuss transmission. COVID-19 is spread by three main routes: normal breathing or normal speaking. So an infected person breathes out, exhales small droplets that may contain the virus. Not necessarily, but they may contain the virus. Forceful actions such as coughing, sneezing, speaking at volume, so loud speaking, or singing. These are what we call aerosol generating actions. These are forceful actions that may cause transmission from an infected to a non-infected person. And lastly, we have fomite transition. This is when you touch a surface, phone, laptop, tabletop, anything that may harbor an infected or a viable virus, and then you touch your eyes, nose, mouth. At this point, scientists and the scientific community believe that transmission through respiratory droplets and aerosols is a primary mode of infection with coronavirus. In normal breathing and speaking, an infected person can exhale small droplets that contain viable. Now, viable means that the parts of the virus has the genetic material intact, the RNA that it will then inject. Also, the spike protein needs to be intact so it can attach the receptor. So a viable viral particle. So when you speak normally, you have droplets from the nose and from the mouth. Most of the time, you cannot feel it. However, an infected person can exhale this and pass it on to someone else. This is a diagram. I'm sure some of us are familiar with these diagrams showing the extension of droplets and aerosol that happens in normal breathing and speaking. So in normal exhalation, it contains large droplets. Now, these droplets are mostly aqueous, so mostly water. Sometimes you can feel it, or most of the times you cannot. Most of the droplets in a normal exhalation or normal speaking will fall within 1 meter, which is around 3 feet of an infected person. Now, exhaled aerosol particles. Aerosol particles are those particles that has been desiccated. So the large droplets contain a lot of water. The desiccated, the water is mostly removed, and what you have is what's called a droplet nuclei. So the aerosol, the droplet has lost most of its water and it's able to float. That's what we call aerosol. And every aerosol begins as a droplet, then gets desiccated and has the ability to float. Aerosols may extend beyond about 2 meters, so beyond about 6 feet of a person, which is why the 6 feet of separation or 2 meter, if you're in other countries, have come up. And it's the most tenable solution. If we had done something more than that, it would not be likely that restaurants, theaters, workplaces, schools could manage to have 9 feet, 12 feet, 18 feet of separation. So we settled on 6 feet being the happy medium. Aerosols obviously can linger as a cloud of viral particles in the air, which is why aerosolization is a more deadly, makes it more easy for the virus to be transmitted from an infected person to a non-infected person because it exists as a cloud and it can linger for hours. they have shown that up to 2 days in the air in a poorly ventilated environment. Here are two diagrams, graphic diagrams of sneezing and the droplets. You see that most of the droplets will fall within about 3 meters, 9 feet. So sneezing and coughing will produce greater aerosolization. So the droplets will be more likely to be aerosolized. The process of aerosolization is very complex. It involves complex wave mechanics and humidity, temperature, the calculation. There are very advanced mathematical models that predict how much. That is well outside the scope of what I'll discuss here. It's just important to note that in a sneeze, there's a lot of aerosol, more aerosol produced than occurs within, as I said earlier, 3 feet. Some of it will, or 3 meters, sorry, some of it will go beyond that. And lastly, I will discuss fomite transmission. So it is possible to be infected through contact with contaminated surfaces or objects, which are fomites. These could be anything like your laptop, again, books, tables, shiny surfaces, anything that contain a virus and a viable virus. You touch that, then you touch your nose, your eyes, your mouth. There is a possibility that you'll introduce viable particles through these receptacles on your face. In the early part of the pandemic, we heard a lot about avoiding touching on the face, which is difficult and probably most impossible for most people. However, the thought there was to reduce the possibility that you will introduce viral particles through these receptacles. Infection through contact with contaminated surfaces. So through contact with fomites is not thought to be the major route of transmission at this point. The highest factors for transmission from an infected to an uninfected person is obviously close contact, so being within 1 meter, 3 feet of an infected individual. Exposure to aerosolized particles, obviously viral clouds. Sitting in a bar, for example, where there isn't a lot of good ventilation, speaking loudly above the din, above noise, above music, at length for a long duration is a very high risk of transmission from infected to uninfected. And obviously, exposure to viral clouds in any pore setting is a high risk for viral transmission from infected to an uninfected person. Right now, I'm going to give just a little bit of an overview of COVID disease. More information is obviously available at the CDC, the World Health websites, or national Ministry of Health websites, Ministry of Health websites for all countries, New England Journal of Medicine, JAMA, and other authoritative guides. I'm just going to give a brief overview of COVID disease as it stands now. I'm going to just reintroduce this. Again, COVID-19 is a disease that results from infection with SARS-CoV-2 coronavirus. Again, I've heard people who think that these are separate things, or one does not cause the other, or they're not aware that SARS is the infectious agent, coronavirus is the infectious agent that may lead to the disease COVID-19. So it's important, again, that we reiterate that point for ourselves and for the public. COVID-19 disease has an incubation period that ranges from 2 to 14 days. So from the time that you become infected to the time that you start to show symptoms is as short as 2 days and as long as 2 weeks, which is why it is quite a dangerous virus, because it means that many people may be walking around asymptomatic and passing on the virus to uninfected and unsuspected persons. In the beginning of the pandemic, there was a heated debate as to whether asymptomatic persons, the persons who are infected with the virus but are showing no symptoms, whether or not they can transmit it. Yes, we know now that they can, and they do. And many of the super spreading events that we see around the globe are because there are asymptomatic people outside going about their lives, but they are unaware that they have an infection and they pass it on to their loved ones, friends, and others. This is why testing often is important even now. Symptoms of COVID disease may range from none at all, again, asymptomatic, you're not aware that you're ill, to mild, you have a flu-like illness, maybe a cold, sniffles, sore throat, to fulminant disease, moderate disease to severe disease, and in the worst cases, leads to a demise, death. Most people, however, with COVID have mild symptoms. Some may have moderate symptoms, and there are those who become severely ill and unfortunately may pass away. 3% of people around the globe, as we say, the case fatality for the globe as well, is 3% at this point. So 3% of COVID cases will result in a demise, a death. COVID, it's important to note, affects every single human being. In the early parts of the pandemic, we were under the impression that although children and young people could be infected, they don't show disease. Well, they do. They are less likely to become severely ill. That is true, but everyone is affected by the disease and can be affected by the disease. Persons 65 years and older are more likely to suffer severe illness, moderate to severe illness. Persons with underlying conditions, for example, diabetes, for example, cardiac problems, asthma, other respiratory issues, obesity, cancer. These individuals are more likely, if they become infected and develop COVID disease, they're more likely to have a severe course of illness. Immunocompromised individuals, people who are on immunotherapy for cancer and other diseases, or who have autoimmune diseases, are at greater risk of a severe, moderate to severe disease outcome for COVID disease. Disease sequelae. So the consequences of having had a COVID disease range from having mild respiratory sequelae, so having a sore throat that lingers, to multi-organ manifestations. Some of the manifestations are neurologic, dizziness, headaches. Some of them are renal, kidney problems. Some people have ended up with end-stage renal disease after having had a COVID disease event. It is rare, but it happens. Hepatic liver disease is one of the manifestations. We have gastrointestinal manifestations, for example, diarrhea, nausea, vomiting, abdominal pain, and a lot of this continues post-recovery. Thromboembolism is one of the sequelae of a COVID disease event. We have cardiac manifestations, so myocardial injury, myocarditis, we have arrhythmias, we have cardiac shock as well. We have endocrine manifestations, and we have dermatological manifestations, rashes. Women especially have complained about loss of hair, loss of thickness of hair. These are just some of the extra pulmonary manifestations of COVID. So outside of the pulmonary system, we have the multi-organ disease. Obviously, really detailed discussion of each manifestation is outside the scope of this talk, but you can get more information from any good medical journal, the CDC, the World Health Organization, Ministries of Health websites around the world. There are, of course, long-term issues around COVID. We know that there are people that have what we call long-haul COVID or long-term COVID. It is at this point still one of the least understood consequences of COVID-19 disease. Symptoms of a long-term COVID event or disease may include, but is not limited to these, but may include shortness of breath. So people 9 months after recovery from COVID are complaining of still having shortness of breath upon effort or activity. Cognitive dysfunction is what we hear of a lot. Brain fog is commonly called, but there are people that complain about not remembering things, not remembering how to do simple tasks, not remembering how to do tasks that they have done well all their lives. So there is a cognitive dysfunction for a lot of people. It is frightening. It is a loss of control. It's a loss of the activity that they most depend on. We have issues and symptoms that may include chronic and debilitating fatigue. This seems to be more prevalent in females than in males. At this point, we do not know why, but chronic and debilitating fatigue is one of the long-term conditions of having had a COVID infection. Joint pain is common, and rapid heartbeats and arrhythmia. There are, at this point, or there may be up to 200 additional symptoms. Again, a discussion of those is outside the scope of this discussion. We do not really have the time to discuss all of these, but you can do some research and find out what these are. But the most important thing to take away from this is there is a long-term sequelae of COVID for some people. At this point, we do not know why some people are more likely to suffer from long-term COVID, and we do not know if there are factors that would render one more likely to have a long-term event with COVID. We do know, though, that shortness of breath, cognitive dysfunction, and heart problems are the biggie in long-term COVID. And scientists are working on trying to understand this. Unfortunately, as with anything else in life, there are myths and misconceptions. So there are myths and misconceptions around COVID-19. The most common include issues around what questionable remedies, so things that people are doing to cure themselves of COVID. Very hot baths will not cure anyone of COVID. Your body temperature remains the same. The virus will not die if you're sitting in a very hot bath, for example, but you will burn your skin and possibly cause heat shock, and die. Very cold temperatures in the same way will not cure you of a COVID illness. Your body temperature remains the same, around 98.6 plus or minus about 2 degrees. You will be cold. You might develop hypothermia, but the virus will be very nice and toasty like the rest of your internal organs. Ingesting copper solution is not a cure for COVID. It is not even a good idea. Ingesting horse and animal or cattle dewormers, large animal dewormers, ivermectin, most of us are familiar with that name, that will not cure you of COVID, but it may cause problems for you later on. It is never a good idea to use medication that is not indicated for human use. Ingesting various herbal teas, vervine bush, for example, periwinkle tea, and others is not a cure for COVID. It's not a bad idea to have a nice herbal tea once in a while. I like mint myself. I've never had vervine, but it is not a cure for COVID. And as with any other illness, it is important to consult with medical health professionals for management of a COVID-19 illness. Do not try to solve the situation on your own, especially if you have a moderate or more severe course of the illness. All right, so I'm going to just go into a discussion of where we are now in this pandemic, COVID 2019, and just do a comparison with the 1918 pandemic. We're in the third year of this pandemic. We are at this point at 5.3% of the world population infected. It sounds like a small number, but it is, as we had discussed earlier, 426 million individuals around the world infected. So 5.3% of our current total of the world population. Deaths are at 0.08%. Mercifully a small number, but imagine too many anyway. We did discuss earlier that we're at 5.9 million. We're at close to 6 million persons having perished because of COVID. 0.13% of the world's population has been vaccinated. The world population, as of this morning, when I looked, it was 7.89 billion persons. I rounded that up to 7.9 billion. If we compare our pandemic today with what's happening, or what happened in 2018, so the 1918, the 1918 Spanish flu pandemic. This was an H1N1 virus. H1N1 is a swine virus. This lasted 3 years, 1918 to 1920. 30% of the then population, which was 1.8 billion, that's an estimate, 30% of the world's population was infected with the Spanish flu, with H1N1. That represents about 500 million individuals. We're approaching that closely now with the COVID at 426 million. 3% of the world's population was killed by the Spanish flu. That equates to about 50 million people. We're at this point, 5.9 in war pandemic, but at that time, about 50 million. And these are estimates, but 50 million persons perished because of the Spanish flu pandemic. The world population then, as I mentioned earlier, was 1.8 billion individuals. At that point, there were no vaccines, there were no therapeutics. Persons were only given supportive care for the illness. So we are here now, the COVID 2019 pandemic. We have a deeper understanding as compared to the beginning of this pandemic, a deeper understanding of the agent, the coronavirus, SARS-CoV-2. We have a deeper understanding of COVID and its sequelae. In the very beginning, we all know the stories about hospitals and people dying in hallways. Doctors did not know how to treat the patients. They did not know how to monitor them. They did not know what to do for them. It was a very situation. We know now, we have better information. We know now how to manage patients as best we're better off than we were at the earlier part of the pandemic. 9 vaccines are authorized for use. So we have 9 vaccines that are authorized globally. The most prominent in the Americas is Pfizer's mRNA vaccine, Moderna's mRNA vaccine, and Johnson & Johnson's Janssen vaccine, which is not an mRNA vaccine, and this is a 1-shot dose. The others are 2 doses, 3 now, and a booster. Wide availability. So at this point, we have wide availability of personal protective equipment. We have masks and sanitizers for use, especially in first world nations. We have multiple therapeutics available for hospital and outpatient care. Treatment for we have Veklury, primarily used in hospital treatment. Veklury is otherwise known as remdesivir. It is also used in combination as a combination therapy. Can be used in outpatient facilities, but most likely in hospital care where the patient can be carefully monitored. We have Paxlovid. It's an oral antiviral medication developed by Pfizer's pharmaceutical. We have Molnupiravir. It's another oral antiviral medication. This one is developed by Merck Pharmaceutical. We have convalescent plasma, and we also have monoclonal antibody treatment. Convalescent plasma and monoclonal are to be used only for patients who have a very, very high risk of a severe outcome for COVID. So people with multiple underlying conditions, or who are immunocompromised, or who are over the age of 65 and most likely to have a severe disease course. Right, so what is the next phase of the pandemic? Earlier we discussed phases 1 and 3, where there was only predominant animal activity. We discussed phase 4, sustained human-to-human transmission, which is the precursor to declaration of a pandemic. We are at this point. So we are now in the pandemic. The next phase could be that we remain in the pandemic phase indefinitely for a period that is, we do not know when it will end. Some scientists believe that we are best to keep this designation until a point where we can absolutely guarantee, which is usually not possible, that we will not have recurrent events. Most scientists, however, agree that we should consider moving to a post-peak phase of the pandemic. That is to say, we're past the peak, but we will have recurrent events. For example, Omicron or other variants popping up. But we may be in the post-peak period, according to what many scientists and public health bodies would like. And then obviously we are going to be looking to go into the post-pandemic phase. We're not there yet. We're maybe in the post-peak phase. We're definitely in the pandemic phase, but where we go next depends on what happens. So the post-peak is where we have more events, but we're past greater peaks. Post-pandemic is when there is a disease activity at what we call seasonal levels, so the flu. At this point, There are different jurisdictions that are executing disease mitigation activities that is appropriate for their own needs. For example, California is now moving to what they're calling an endemic designation, meaning they're going to treat the pandemic as if it's a regular flu. They're going to manage it as if it's a regular seasonal flu. Different countries are executing mitigation strategies that are outside of the WHO pandemic designation. Yesterday, the United Kingdom announced that it was dispensing with all COVID-19 mitigation and containment strategies. So if someone tests positive for coronavirus, they at this point will not have to, they're not going to be asked to isolate or to quarantine. UK is dispensing with all of that, and they're relying on people, the populace, to maintain their own mitigation and containment strategy for the good of themselves and for the good of the community. We do hope that that will work. However, the UK is the first country that we are aware of that's moving to that strategy. Australia has just opened up its borders again to all tourists, and it is very likely that their neighboring countries, the Solomon Islands, the Fiji Islands, New Zealand, and other surrounding countries will follow suit. Ultimately, though, the World Health Organization is responsible for designating the next phase of the pandemic. WHO chief is Mr. Tedros Ghebreyesus. Earlier this year, he declared that the acute phase of COVID-19 pandemic could end by mid-2022. Mid-2022 is June, if 70% of the global population is vaccinated. We saw in an earlier slide that at this point in the pandemic, we are at 0.13% of the global population vaccinated. It is very hopeful, very, very hopeful that by mid-2022, which is June, we will be at 70%. It isn't impossible, but it is a hopeful statement. However, that is what the chief of WHO needs to have a designate change from a pandemic to a post-pandemic phase, and then an endemic phase. All right, so these are some of the excellent resources that I have used to construct this brief talk. The Ministry of Health and Wellness is Jamaica's National Ministry of Health site. It's wonderful, has beautiful dashboards, good information. The World Health Organization obviously is a plethora of fantastic information. It's a very big site, very heavy, but it has everything you need about world health. Pan American Health Organization is an umbrella group under the World Health Organization, and it deals with the health information from the Caribbean and Latin America and North America as well. Wonderful resource for information about what's happening in the Americas, Latin America, the Caribbean, South America, and North America as well. The World Bank is a fantastic resource for population information, economic information, and also health-related information as it relates to the economics of a country. Johns Hopkins University in Medicine is fantastic information for statistics, epidemiology, and data. I get most of the data, I get up-to-date data on the hour data from Johns Hopkins University. It has all the nice dashboards. You can see the different countries reflected there. You can drill down to a particular country, a particular nation, and a particular indicator, whether that's death or cases or vaccinations. CDC is a plethora of fantastic health-related information for this particular country, and obviously the World Health Organization is their sister organization for the world. Other resources include the National Institute of Allergy and Infectious Diseases under the umbrella of the NIH, National Foundation for Infectious Diseases. MMWR is a publication of the CDC. It's free, it comes out weekly, and it's a wonderful resource for learning about all the different types of chronic and infectious diseases that are happening within the United States and elsewhere. ProMed is my personal favorite. This is Program for Monitoring Infectious Disease. They are what is considered the canary in the coal mine for many, many emerging diseases. In fact, they were the ones who, one of the partners that worked with WHO to come to the conclusion that we are in a pandemic. So they started reporting viral pneumonia very, very early in the pandemic. ProMed is something that you can subscribe to. I would let you know that if you do subscribe to it, your inbox, your email inbox will be filled. They do update on the hour. You can go to their website and get the information as well, but it is an invaluable resource for learning about whatever emerging infectious diseases are around the world. And I would like to thank everybody at the Jamaica Diaspora Task Forces, the Health Task Force, Dr. Gordon, Dr. Frey, Ms. Brown, and everyone who gave me the opportunity to do this talk. I look forward